Hello, welcome all to the sixth presentation of Cycle 2 Basic Module in Infectious Disease. Myself, Dr. Satyanarayan Reddy, working as a clinical pharmacist, ID forum member, FCPI. I'll be acting as a moderator for today's session. Yeah, before that, I just want to give a few instructions to the participants. Yeah, could you go for the next slide, ma'am? Yeah. Regarding the participants, if you have any kind of queries or any kind of doubts, just please note it down and mention them in a comment section. That would every question would be answered at end of the session. Next slide, please. Yeah. If the regarding feedback at the end of every session, you'll be having an option called feedback just below the comment section. You can submit your feedback regarding the session after the completion of each and every session. Please just let me know your ideas and also any kind of feedback that would be valuable for next improving of the sessions. Next slide. And you can claim your participation certification within 14 working days. So please, you can just come after completing the session, give your valuable feedback, and followed by you can get your certification by next 14 working days. Yeah. Next slide, please. Yes. Participants can download the slides of the presentation after completing of a live streaming. So keep in mind that logging into a website FCPI portal isn't mandatory for downloading the slides. Next slide. Yeah, without any late, I would like to invite our speaker today, Dr. Nishala Reddy ma'am. She's an from the graduate from Sri Venkateswara College of Pharmacy, and she is having a 4 years of experience. Currently, she is working in Continental Hospitals, Hyderabad, and also ma'am is a medical safety officer, and also she's an active member in implementing antimicrobial stewardship in her hospital settings, and she is a standard pillar in these kind of aspect. Now, without any late, I would like to hand over the session to you, ma'am. Please go ahead.
Good evening, all. This is Dr. Nischala. So today we are going to discuss about antimicrobial allergies. First, disclosure information. I do not have any relevant financial relationships with any commercial interest. Today's learning objectives would be about evaluation of antimicrobial allergies, the labeling of penicillin allergy, alternative regimens in patients with antimicrobial allergies. What is a drug allergy? A drug allergy is the reaction of the immune system. One second. A drug allergy is the reaction of the immune system to a medicine. A medicine could be of a non-prescription, prescription, or herbal, which can provoke a drug allergy. Terminologies of adverse drug reactions, where before we label a patient with medication allergy, we'll have to be careful about what type of reaction is it, whether it is an allergic reaction, a side effect, or an intolerant reaction. So let's review a few of the terminologies today. Allergy could be because of the immunological reaction that is happening, which we label the patients as allergic reaction. Whereas side effect could be of pharmacological. Simple side effects like nausea, vomiting, diarrhea shouldn't be labeled as adverse drug reactions. And intolerance could be pharmacological plus susceptibility related. The other terms are idiosyncrasy, genetic susceptibility to ADR, pseudo allergy, various mechanisms which could mimic like an allergic reaction. That can be called as pseudo allergy. That can be because of infusion related reactions as well, which will like directly mimic the true allergic reaction. So these kind of situations may we will falsely label the patients with a medication or antibiotic allergy. Toxicity can be due to adverse drug reaction due to excess dosage. Interaction could be because of drug combinations that we are using in a patient. Next is classification of drug allergies. There are two types of drug allergies, which are immediate hypersensitivity and delayed hypersensitivity. In immediate hypersensitivity, usually these kind of reactions will occur within 1 hour of medication administration to maximum, like it can happen for over 6 hours after the medication has been administered. The symptoms associated with immediate hypersensitivity reactions are angioedema, nausea, emesis, hypotension, urticaria, and bronchospasm. These immediate hypersensitivity reactions are usually IgE-mediated reactions, type 1 hypersensitivity. For these kind of reactions, how do we have to go ahead for evaluation are graded oral challenge, plus or minus a skin and intradermal testing that we have to do. Next, the treatment parameters for these would be desensitization if medication is needed. Delayed hypersensitivity usually occurs within 7 to 10 days after the medication administration. The symptoms would be DRESS, SJS, and TEN kind of symptoms. These delayed hypersensitivity reactions are usually T-cell mediated and type 4 hypersensitivities that we call. So for these kind of delayed hypersensitivities, we cannot do any kind of de-challenge or desensitizations. A proper history obtaining from a patient is mandatory based on the severity of the infection, whether we have to go ahead with intradermal or patch testing has to be considered. Later to that, desensitization with any of the medication is not indicated if the patient complains of severe allergic reaction. Depending on the reaction, pre-treatment or if there's any alternative agent that we could go ahead with. Next is the pathophysiology. According to Gell and Kuhn's classification, there are 4 pathophysiologic mechanisms. First, type 1 is IgE-mediated reactions. Symptoms associated with it are urticaria, angioedema, or anaphylaxis. Type 2 is cytotoxic reactions. Usually, drug-induced hemolytic anemia or thrombocytopenias are observed in type 2 kind of reactions. Type 3 is serum sickness-like reaction. Symptoms associated with it are rash, fever, arthralgias, vasculitis, and organ-specific reactions. Type 4, we call it as delayed hypersensitivity, where the symptoms are maculopapular exanthem. Type 4 is further divided into 4 subtypes again. 4A represents a Th1 mediated reaction involving macrophage activation and presence as an exanthem. 4B is associated with Th2 mediated with eosinophil-rich exanthems or Buller's lesions. 4C is cytotoxic reactions. 4D is neutrophil-rich pustular reactions. So here we are going to see about mechanism of hypersensitivity reactions to penicillin and their clinical manifestations on time of exposure of the medication. So first 3 types, as we have discussed, would be antibody mediated reactions, whereas type 4 would be T-cell mediated reaction. In type 1, if we could see over here, when a patient is exposed to penicillin, there is a mast cell degranulation which is happening. Thereby, there are symptoms associated with it are urticaria, angioedema, bronchospasm, cardiovascular collapse, anaphylaxis. This type 1 reactions usually happen within 1 to 6 hours of exposure of the antibiotic. Type 2, these are cytotoxic reactions where red blood cells is involved in the reaction, because of which we will observe hemolytic anemia, thrombocytopenias, and potassium, which are a rash on the skin, which is usually seen in dengue. Type 2 reactions will usually occur within 5 to 15 days of exposure of the antibiotic. Type 3 is immune complex reaction, where the Ig penicillin is when the patient is exposed to penicillin, there's a degranulation and then causing an increased permeability, which is leading to tissue damage. Thereby, we observe small vessel vasculitis, serum sickness kind of reactions. These reactions usually happen within 3 to 21 days of exposure of antibiotic. T-cell mediated, which is driven by CD4 and CD8 cytokines, where we observe a series reactions called DRES, SJS, and TEN kind of reactions. These are very delayed kind of reactions. Usually we observe post 42 days of exposure of antibiotic. What is an anaphylaxis criteria? So with what symptoms do we have to consider that it is an anaphylaxis reaction? Any one of these criteria, if it is fulfilled, then we call it as anaphylactic reaction. First is acute onset of an illness, which occurs from minutes to several hours with involvement of skin or mucosa, causing pruritus, flushing, hives, and angioedema, or involving respiratory symptoms or respiratory compromise, dyspnea, wheeze, bronchospasm, and decrease in expiratory flow, stridor, hypoxemia, or there could be hypotensive episodes or end organ dysfunction. Next is 2 or more of the following that occur rapidly after exposure to a likely allergen for that patient, involving again skin or mucosa, respiratory compromise, hypotensive episodes, along with end organ dysfunction. Along with all of these symptoms, there could be persistent GI symptoms involving vomiting, crampy abdominal pain, and diarrhea. Third would be after exposure to a known allergen for that patient, minutes to several hours, we see hypotensive episodes. So how do we have to evaluate a patient with antibiotic allergy? A detailed history is required to label or delabel a patient with antibiotic allergies. First would be timing of reaction in relation to drug administration. At what time it has happened after administration of medication, so as to grade which type of allergic reaction is it. Symptoms and evolution of reaction. What are the symptoms? Based on that, we could grade what risk is it associated with. Nature of reaction, whether it is like just cutaneous reactions or symptomatic reactions, whether it is just nausea and vomiting, that we have to differentiate. Description of cutaneous reactions, intolerance or non-allergic reactions, involvement of mucosal surfaces or internal organs, treatment administered and response and duration of reaction. Next would be other medications ingested at the time of reaction. History of prior exposure to the implicated agent. Was there any medication, similar medication taken thereafter, and was it tolerated? If there are any potential confounders. History of other reactions and allergies. If the patient had experienced a similar kind of reaction without known exposure, the likelihood of future need of the same medication, and lastly, which antibiotic are being tolerated by the patient since the time of reaction. Next is coming to drug infection interaction. There are infections which can mimic the drug allergies as well, because of which also we could falsely label patients with the drug allergies. First would be the rash observed with Epstein-Barr virus and aminopenicillin treatment present in at least 30% of such patients, which is like bacterial and viral infections are directly linked to onset of erythema multiforme mimicking SJS. Next is a more traditional illness that resembles SJS and TEN, which has been associated with a virus such as Coxsackie A6. Next, going ahead with cross-reactivity, delabeling, and test dose practices with each of the antibiotic. First, let's start with penicillin allergy. Patients with a history of penicillin allergy are more likely to be treated with less effective, more toxic, expensive antibiotics, leading to increased cost burden on the patients, and antibiotic associated infections like C. difficile infections because of usage of other antibiotics, which are leading to C. difficile, which will further elongate the hospital stays. Uh, Even increased mortality that could be associated with resistant organisms like MRSA and enterococcal infections. Cost and simulation model-based economic studies support that penicillin allergy assessment is a cost-saving intervention. Epidemiology. Let us discuss about 5 facts about the penicillin allergy. Approximately 10% of all US patients report having an allergic reaction to a penicillin class antibiotic in their past. However, many patients who report penicillin allergies do not have true IgE-mediated reactions. When evaluated, there's only 1% of population are truly allergic to penicillins. Approximately 80% of patients with IgE-mediated penicillin allergies lose their sensitivity after 10 years. So considering this, if a patient has childhood penicillin allergy, so we can go ahead with delabeling the patient with penicillin allergy. So considering this 10-year period of time. Correctly identifying those who are not truly penicillin allergic can decrease unnecessary use of broad spectrum antibiotics, which could further uh, develop resistance in the patients. Cause of falsely labeling penicillin allergies in the patients. What could be the reasons? So patients incorrectly labeled as allergic when their symptoms actually represented intolerance. That could be simple side effects or intolerance, or it could be any kind of pseudo allergic reaction, which is mimicking the true allergic reaction. Patients experiencing a viral or bacterial exanthem, as we have discussed, when administered while taking any of the antibiotic, if there is underlying bacterial or viral infection, or be it dengue infection, which is happening simultaneously, we could falsely label the patient with a drug allergy. Loss of immunity over time, as we have discussed, some immune-mediated penicillin reaction may not reliably recur when rechallenged, because mild delayed T cell mediated reactions could wean off over time. So they might not be sensitive to the penicillins no longer. Knowledge gaps due to lack of allergy training amongst healthcare professionals, resulting in incorrect diagnosis. There could be system barriers as well, where there are no proper EMR systems in many of the institutions where we can label it as different as side effect or intolerance, because we mostly have seen EMRs having only allergic symptoms being documented. Strategies for penicillin allergy delabeling. So first and foremost thing would be uptaking the history of the reaction and comorbidities of the patient. Second is skin testing. Next is benign cutaneous reactions by direct amoxicillin challenge. And then allergic history, such as non-allergic reactions, or if a patient says there is a family history, these set of patients can be directly delabeled. So first, let us discuss about the skin testing. The skin testing can be performed by two-step modality. First is a prick test, typically which is performed on the forearm, followed by an intradermal test, which is performed on the upper arm. On this intradermal test is usually performed only if the prick test is negative. A prick test involves 4 components where histamine, saline, benzyl penicillyl oil, polylysine, and dilute penicillin we consider. Histamine is considered as a positive control. Usually after giving histamine, there is a wheel that appears, which is compared against a negative control or the major determinant or minor determinant that we are administering to the patient. Saline, where there is no reaction that happens at the spot that we administer saline, and major determinant and minor determinant are compared against these two positive and negative controls. Here, if you could see, the slide is not clear. If a wheel is If you measure the size of the bleb that appears on the skin, if it is measuring less than 5 mm of diameter, then it is a negative skin prick test that we call. And if it is more than 5, then it is a positive skin test. If the skin test is negative, then we are going ahead with an intradermal test interpretation. So here also we use the same kind of reagents and then test it again on the upper arm. So if the wheal size is more than 3 mm, we say it is positive. And if the wheal size is less than 3, we say it is negative when compared over negative and positive controls. Next would be if the skin test is negative, then the next challenge would be testing with an amoxicillin oral challenge. A common challenge to disprove Ig-mediated penicillin allergy by two-step amoxicillin challenge is by administering a lower dose of the actual dose of amoxicillin, which is we could start with 50 mg of amoxicillin and observing the patient for 30 to 60 minutes. If there is no reaction or if the patient tolerates this dose, then we can go ahead with increasing the dose to 500 mg and observing the patient for another 60 to 90 minutes. If there are patients with low risk allergy reported, then we can directly go ahead with one step challenge, which would be doses would be 250 to 500 mg and observing the patient for 60 to 120 minutes. There is a pen-fast tool that we can assess the reactions, allergic reactions for delabeling. Development and validation of a penicillin allergy clinical decision rule that we are going to discuss. If a patient has already come reported with a penicillin allergy who had come to a hospital, then we can go ahead with this pen-fast rule, which is you'll have to ask the patient if the allergic reaction has appeared within 5 years or less since the time of reaction. Then we can label them as, then we can grade them with 2 points. And if the reactions are associated with it are anaphylactic or angioedema, severe cutaneous adverse drug reactions, then again 2 points we have to score them. And then what treatment was it required for the reaction which has happened, whether the treatment was required or it has subsided without giving the treatment. For that, we grade them with 1 point. So here, when we are assessing a patient, there is a timeline that is involved when the reaction has happened, the symptoms, what kind of symptoms that they have experienced, and whether the treatment was given to that patient when previously the reaction has happened. So the interpretation of the points would be 0 is very low risk to 4 to 5 would be high risk. Penicillin allergy delabeling, we have different things that we have to work on to delabel. There should be an institution health system, workforce, infrastructure, operations, and workflow. There should be set protocols that we need to have in hand before we start penicillin allergy delabeling. Excuse me. Innovations and research, we have to keep ourselves up to date for new, safe, and effective implementation strategies so that we can go ahead and delabel. And policies and procedures should be in place before we start. Testing resources, there should be a space for delabeling, performing a delabeling of antimicrobials anti-allergic medication delabeling kits also should be made available. Training of all over specialties is mandatory because penicillin allergy delabeling is not widely conducted in various specialties. Education of healthcare professionals and patients as well on their delabeling or relabeling is mandatory. Also, having an EMR where we can enter the medication allergies whenever we delabel and relabel, so that for the admissions, the same record can be continued. Next, coming to cephalosporin allergies. Immediate allergic reactions to cephalosporin appear largely to be related to antigenic responses. Usually, cephalosporin allergies are because of this R1 side chain that is being shared. If we can see in this slide, so the R1 chain is being shared by the penicillin group, the cephalosporin group, and the monobactams, whereas it is different for carbapenems. So there is the reactions which are happening because of cephalosporin are not because of the beta-lactam, core beta-lactam ring that is present either in any of these group of antibiotics or because of R2 chains. So from this structure, we could say that if there's any kind of reaction based on the symptom or based on allergy risk stratification, we can give carbapenems to these set of patients. Next is cephalosporin administration to a patient with penicillin hypersensitivity. If we are going ahead to give structurally similar cephalosporins, so what do we have to assess first is, was there any anaphylactic reaction that has happened when previously exposed to penicillin? Then in that case, penicillin skin testing guided treatment would be the recommended option. If the penicillin skin testing is positive, then drug challenge would be a higher risk. If the skin testing is negative, cephalosporins can be administered normally. And if you're going ahead with structurally dissimilar cephalosporins, or even if the structurally similar cephalosporins, if the patient had any kind of non-anaphylactic reaction, then the recommended options would be cephalosporins. And other options would be cephalosporin administered by drug challenge, penicillin skin testing, guided treatment. Next, we would be discussing about beta-lactam cross-reactivity. If there's any patient with unverified or non-anaphylactic penicillin allergy, without any further ado, we can give any kind of cephalosporins routinely without testing or additional precautions. If there's a patient who has come with confirmed penicillin allergy with a positive skin test and history of anaphylaxis, even in these set of patients, there's only 16% of cross-reactivity is associated with first and second generation aminocephalosporins, whereas only 2% of cross-reactivity is associated with third and fourth generation cephalosporins. In contrast, for those with rare patients with a history of anaphylaxis to penicillin, a non-cross-reactive cephalosporin, which is a safe cefazolin, can be administered routinely without prior testing. That means it could be like the patient can be allergic to penicillin or cephalosporin. The cefazolin is not sharing any kind of side chains with any of these two classes. So cefazolin is safe to give to patients who are reporting penicillin or cephalosporin allergy. Next is carbapenems. Carbapenems can be administered in penicillin or cephalosporin allergies. As we have seen, they are structurally not similar with, they are not sharing R1 side chains with penicillins or cephalosporins. To administer carbapenems, there is no prior testing required, regardless of whether a reaction was anaphylactic. Monobactams called Aztreonam can also be administered in patients with penicillin or cephalosporin allergic. There's no prior testing required even in these cases until and unless if the patient had an allergic reaction with ceftazidime, because even ceftazidime and Aztreonam share identical R1 side chains. So this is the picture that we can see where Aztreonam and ceftazidime are sharing similar R1 side chains, because of which if a patient is reported with any one of these drug-associated allergic reactions, the other should be avoided. Next, coming to allergy risk stratification, as we had been talking about how severe the allergic reaction is, we are going to grade them into low, high risk, and severe non-IgE related allergic reactions. So if the patient is like reporting with an allergic reaction more than 10 years or unknown reaction, if the patient denies any kind of allergy, but it is there on the record saying that the patient is allergic to penicillin, or if the patient had any previous symptoms like pruritus without any rash or urticaria, hives with no other symptoms, then in these set of patients, the delabeling strategies would be, the first is delabel. Like a patient who has experienced allergic reaction in their childhood, which has exceeded more than 10 years, or a patient who is denying allergies, which is not there on the record. For these set of patients, or a patient who has a family history where the patient himself has not experienced anything during the entire life. So for these set of patients, we can directly delabel them. Whereas with minimal or low risk kind of allergic reactions or symptoms, we can go ahead with direct oral two-step graded challenge that we have seen with amoxicillin. So what would be the appropriate antibiotic selection for these set of patients? For low risk penicillin allergy, any kind of cephalosporins can be utilized. Whereas for low risk cephalosporin allergy, any penicillin can be utilized. Other than this, the cephalosporins with dissimilar side chains can also be used. Like there are, I have mentioned in group A, group B, and group C, where the antibiotics are sharing similar side chains. These antibiotics to be avoided. If for suppose in group B, if we see, if a patient is allergic to cefepime, then we'll have to avoid ceftriaxone, cefotaxime, and cefodoxime. Other than that, the group A and group C can be administered. Next is high risk allergy. The symptoms would be anaphylaxis, respiratory symptoms, angioedema, swelling, cardiovascular symptoms. Cardiovascular symptoms would be syncope, passing out, and erythemias. So delabeling strategies would be penicillin skin testing followed by oral graded challenge. If both are negative, then in these set of patients, we can use cephalosporins with dissimilar side chains, and carbapenems can be used in these set of patients. The only cephalosporin that has identical side chain with penicillin are cephalexin. This cephalexin to be avoided even if there are, if the patient is penicillin allergic. Other than this, all other side chains with cephalosporins like cefazolin, as we have discussed, even if the patient is allergic to penicillin or cephalosporins, the cefazolin can be administered without any testing as well, because it doesn't share any identical chains. For high-risk cephalosporin allergy, carbapenems can be used, but we'll have to avoid penicillin and cephalosporins. Next is severe non-IgE allergy, where organ damage involving kidney or liver, drug-induced immune-mediated reactions like anemia, thrombocytopenia, leukopenia, where all the RBCs are being involved over here, where we see all hematologic reactions, rashes, SJS, TEN kind of reactions will happen. In these set of patients, we cannot take risk of delabeling strategies by either by skin testing or oral graded challenge. So in these severe non-IgE related reactions, we'll have to avoid penicillin, cephalosporins, and carbapenems. Astrinum may be utilized except if ceftazidime or cefiderocol is the allergy that has been reported by the patient, because ceftazidime, cefiderocol, and astrinum has similar side chains. So here is a table that we can see for beta-lactam cross-reactivity. If we see over here, green indicates no similarity, towards red it is identical side chains. If we could see in this table, red is mostly seen for ampicillin and amoxicillin, which is sharing side chains with cephalexin, cefadroxil, cefatrizine, and cefaclor. Other than that, there are not many antibiotics which are sharing similar side chains with penicillins. Next is sulfonamide allergy. Patients with documented history of sulfonamide allergy, we could directly challenge them with like two-step. There is a two-step procedure that we have, which will usually be completed within 2 to 3 hours. For patients with benign cutaneous reactions involving morbilliform drug eruption or any kinds of urticaria, if a patient is reported with sulfonamide allergy more than 5 years ago, we can go ahead with one-step drug challenge as we had done with the oral amoxicillin. If there is any reaction which has happened within past 5 years, we can go ahead with two-step challenge. In one-step challenge, what do we do is we could administer the therapeutic dose as a single step and observe the patient. Whereas in two-step challenge, we usually give 10 to 25% of the final dose and observe the patient. If there is no reaction, The rest of the dose can be administered and observed for 20 to 30 minutes for further reactions. Fluoroquinolone allergies. Immediate type reactions have been increasingly described with fluoroquinolones. There's an evidence for both IgE mediated and non-IgE mediated mechanisms because they may cause non-specific mast cell degranulation via interaction with surface receptors. Mostly we get to see fluoroquinolone and vancomycin reactions. These could be because of the infusion rates as well. So usually we'll have to keep longer infusion rates for fluoroquinolones and vancomycins. These are not true allergic reactions if we could run the infusions for at least 2 hours. So these are some of the studies that have been conducted for fluoroquinolone cross-reactivity. First study is involving 12 patients with immediate hypersensitivity reactions to fluoroquinolone, where oral rechallenge with different fluoroquinolone was conducted. Levofloxacin reported to have the lowest cross-reactivity. Next study that considered 57 cases with hypersensitivity to fluoroquinolone, received a challenge with different fluoroquinolone, and cross-reactivity varied least with moxifloxacin. So next we'll have some questionnaires. So the first question would be, a 26-year-old female with known group B streptococcus pollinization is admitted for delivery, who has a history of penicillin allergy. Her parents told her that she had a rash during her childhood. Which of the following can be given for surgical prophylaxis? You can think and drop your answers as well. I'll discuss the answer. I'll give you like 10 seconds. So the answer would be cefazolin over here. Even if the patient, the first and foremost choice for surgical prophylaxis would be cefazolin. If there is any patient with penicillin allergy, we tend to go to like the second option would be clindamycin or vancomycin. Here, why aren't we choosing clindamycin or vancomycin with a reported penicillin allergy? This penicillin allergy patient had during her childhood. The patient is 26-year-old, and furthermore, we could safely give cefazolin because it doesn't share any structural similarity with penicillins. Hope you got the answer. The second question would be patients with a confident history of high-risk allergy to a penicillin other than ampicillin or amoxicillin, whether or not can we give any kind of cephalosporin, whether it is true or false. I'll give you 10 more seconds. You could think about the answer and then I'll discuss. So the answer would be false because here the question says that the patient has high risk allergy to a penicillin. So we already have discussed that cephalosporins with similar side chains in high risk allergic patients should be avoided. So all kind of cephalosporins should not be given, with one example being cephalexin, which share the side chains. Next question is on a 72-year-old man is admitted for elective knee replacement with a history of possible rash to amoxicillin during early childhood. Which of the following is the next best step to evaluate this patient's reaction to penicillin? Option A would be penicillin skin testing plus oral challenge to amoxicillin. B is direct oral challenge to amoxicillin. C, avoidance of all beta lactams. Try and get your answers and I would be discussing. So the answer would be direct oral challenge to amoxicillin. Here, if we could see, the patient had experienced during his childhood where the symptom has, like, the reaction has crossed more than 10 years. So we grade these kind of patients, and the reaction which has happened is also simple rash. There's no other symptoms that are associated with the reaction which had happened back then. So this reaction, we label it as low risk allergy. And for low risk allergies, we can directly go ahead with direct oral challenge to amoxicillin. Next question is a 32-year-old male patient with known penicillin allergy with symptoms of angioedema and respiratory symptoms. Which cephalosporin is supposed to be avoided? Which cephalosporin is supposed to be avoided? Options are A. Cephalexin, B. Cefazolin, C is ceftriaxone. I hope by now you all have got this answer. The answer is cephalexin, because we have discussed it clearly that the cephalexin only shares similar side chains with penicillins. So that's the reason we'll have to avoid this cephalosporin. The answer is cephalexin. Next is the spectra that we can. These are the like cross-reactivity spectra that we could see over here for all the cephalosporins, penicillins, and carbapenems. So the red would indicate potential cross allergy based on similar R1 side chains. The yellow indicate potential cross allergy based on similar R1 and R2 side chains. The white indicates there is no risk of cross allergic reactions. Next is the key take away points from the discussion that we had today would be inappropriate documentation of antimicrobial allergies, which will lead to usage of broad spectrum antibiotics, thereby contributing to AMR. Intolerance or non-allergic reactions will not be termed as allergy and can be delabeled. Identifying false penicillin allergy is a vital component of antimicrobial stewardship program. These are some of my references. Thank you. So the next upcoming sessions for the FCPI are clinically significant antimicrobial interactions, which is scheduled on 28th April 2024 on Sunday at 7 p.m., which will be handled by Aisha Sana. Next presentation would be on penetration of antibiotics to different body sites on May 5th, 2024, Sunday, 11 a.m. to 12 p.m., which is handled by Surabhi. Next is on Critical Care Medicine Forum, top papers in critical care medicine, which is scheduled on May 8th, 2024, Wednesday, 5 p.m. to 6 p.m. by Dr. Rajan Barokar. Thank you.
It's very wonderful session, ma'am. Thank you for adding your valuable insights, because this is one of the unique topic where this can add an good impact on patient quality and also the economical burden. There are good points to learn regarding the low risk patient, high risk category, and also the kind of differentiating one with another, the side chain linkages. So it was very detailedly explained. Thank you so much for your session, ma'am. From participant side, there are few questions. I just want to go ahead. Can I? Hello.
Thank you so much. Yeah, you may go ahead.
Uh, yeah, thank you, ma'am. Firstly, the first question is, when a patient exposed to first dose of penicillin, he had a complaint of itching, rashes, and complete redness all over the body. And this can this be considered as a true allergy, or should it be monitored further?
So can you tell me if the patient has already labeled with penicillin allergy, or is it the first time?
It's the first time as per the question, ma'am.
Okay. So whenever there is any kind of allergic reaction or rash associated, we'll have to like cancel out on other reactions. Uh, Excuse me, there's some disturbance that is going on. Yeah, sorry. So we'll have to evaluate whether it is like a side effect, whether it is infusion related reaction, or it could be anything because of the medication that we are administering. It could be the batch, or if there is any continuous reaction that is happening with one particular batch, that also will have to evaluate before labeling a patient with penicillin allergy. Hope I have answered your question.
Yes, ma'am. It's answered. And there are a few more questions. Like, how can a CP really contribute?
1 second. The volume is, yeah. Yeah, go ahead.
How can a CP really contribute in adding a word to AMS while tracking this antibiotic allergy status, all these things, ma'am? How can it would be helpful, and what are all the ways to approach while we are dealing with these cases?
Okay. So, first, a clinical pharmacist being there is very important because obtaining a history from a patient, like if they are already penicillin allergic or if they are already labeled with any kind of allergy, obtaining a history, what kind of reaction was it, how, like the timing of the reaction, whether there were any confounding factors, or if there is any reaction which has happened at that particular time as well, if there are any like multiple drugs which are running, infusion reactions, whether it is, or if there's any other associated confounders that we'll have to evaluate before we could do delabeling or rechallenging of the medication.
Understood. And also, could you please brief about what is true allergy and what is pseudo allergy, ma'am?
Pardon, I did not get you.
How to differentiate the true allergy and the pseudo allergy while we are dealing with an antibiotics?
So, as I've mentioned, pseudo allergy can be because of many kind of things. Like it could be because of infusion reactions, as I've mentioned, because of any of the drug, spurious drug. Because of that, also the reactions might happen, or it could be infection interaction with a true, like mimicking the allergic reaction, as we have mentioned, like underlying infection with bacterial, viral, or dengue infections can also, the patients might also present with skin allergies or rashes and all, so which might mimic the uh, allergic reactions when antibiotics are administered. So these set of patients will have to be extra careful to differentiate whether that is because of the underlying infection that the rashes or pruritus have occurred, or because of the administration of the antibiotic.
Noted. Thank you for answering, ma'am. And one more question. If the skin test was positive, I mean, if the intradermal test is positive, and if there is no alternative for a patient, how to approach this kind of patients, and what is the best way to approach in clinical settings?
So if the skin test is positive, if there is like what kind of reaction is happening to that patient, we'll have to observe carefully. Like whether it is like low risk, high risk, or severely that the reaction has happened, that we'll have to evaluate. Based on that, the allergic risk stratification, how I've mentioned, based on that, the delabeling evaluation techniques have to be followed. Based on that, and the treatment options are also available.
And what is the exact concept of desensitization, ma'am?
Desensitization, as in if the patient is, we call a patient sensitive to penicillin, and then if whether they are sensitive further or whether they are that like if we have to check whether they are still sensitive, we do have to again administer that medication to see whether the patient is still allergic to penicillin. That process we call it as desensitization.
Yeah, yeah. Uh, yeah, these are all the questions, ma'am. Thank you for adding your insights to it. And
Thank you.
it's
Thank you for having me here. Thank you, FCPI. Thank you. Good evening, all.
bye bye, all. Have a nice day.